Well, thank you so much for allowing me to be here today. And as you can see, my name is Dr. Wallace Wong. You can just call me Wallace. And I have been a psychologist working with transgender children and youth since 1996. And so I'm glad to be here. And then I think that that's enough about me. And let's get right into the presentation. So today we're talking about working clinically with transgender children and youth in BC. And I just would like to share my experience working with this population and hopefully be able to give you some insight about this, what I do. Good, I'm getting it. So this is just some objective of what we're doing today. So learning different about the research about this, learning about different clinical diagnosis of this population, understand the transgender youth and the hormone treatment, working with the parents and families, and then addressing family resistance and conflict. I think the purple part is the part that a lot of people will ask me that questions is what if one parent say yes, the other parent say no, and what if both parents say no, what should I do? And the kid come to my office, and I got that question quite a bit, so I think that part would be important to talk about a little bit. So when we're talking gender identity, just a quick visit is, of course, an individual, personal, and subjective inner sense of the self of belonging to a particular gender. As interesting as it is working with children and youth with gender identity concern, they do know who they are. And many of them, they know very young. I always say people always were quite surprised. My youngest patient is almost just 3 years old. And the first thing that they know that I'm a boy or I'm a girl or I'm something else. And you can imagine how surprised the parent will feel when the first thing they tell you is not mommy, daddy, I love you. It's mommy, I'm not a boy, or mommy, I'm not a girl. So you can imagine, and then a lot of times the parent don't know what to do, and they bring it to your office and then drop the kid off and tell you, fix him or fix her. And what are we going to do, right? So maybe we can get to talk about the population here. So in the natal males, for the transgender population, estimate about like from 0.5% to 1.4%. For natal females, about 0.3%. And 1.3%. So technically, when this statistic come out, the population is quite small. And you can imagine why the world spends so much energy and pass so many laws target this 0.5% population. You can imagine, if you look at the US law right now, more than hundreds of laws waiting to pass, already passed against transgender people. Very interesting to see. So why older estimate 1 in 11,000 to 45,000 are quite outdated. So probably one of the reasons is now there's an improved identification. They have greater access to gender specialists, and affirmed care has increased accurate reporting. And I think a lot of people, I always get to ask this person, why so many people coming out right now? They come to us. Is it because we as a people encourage them to come out, or we make them trans? A lot of people, they say that. But surprisingly, many of them, with the information being more available, they kind of know who they are and be able to advocate who they are to us. And then also the cultural shift. So masculinity in natal females is more socially accepted, leading to historical undercounting. So which is very true. And then when we're working with this population, a lot of times that we will see is when you are assigned male at birth and you're coming out at an early age, your parents will let you be who you are. But the day that you go to grade 1 or grade 2, your parent want to find someone to fix their kid. Why that's the case? Because our society don't tolerate a sissy boy. But if an assigned female at birth, just be a tomboy, it's okay. Just let them be. As a result, what you can see is you may see a lot of assigned male at birth, assigned female at birth. They identify as male. They become C us a bit later in their development because they just like allowed to be who they are until they meet the puberty. They cannot deny it anymore. They cannot ignore it anymore. Then all of a sudden, as you see a lot of struggle, challenges happening, and they come seek help from us. Also, there may be some methodology flaws there. So all the study rely on clinical and medical record and missing on the non-binary population and non-medical transitional individuals. So a lot of people, they are not being accounted for. And also key barriers and risks. So lack of access to care. So 30% of trans youth live in more than 100 miles away from a gender clinic. So which is very true, especially in the BC area. So if the kids want to have assessment done or want to have some support done, a lot of times they need to find the medical or professional that are able to provide care for them. A lot of times in the smaller rural area may not have a specialist available. As a result, they may not be able to access the care that they need. And then also, next one may be the key barrier, low, and the next one is suicidal risk. So up to 40-50% of trans youth attempt suicide, so which is quite sad. So some of them, they didn't even be account for this statistic because they end their life too soon. So the reason for incident that we see is younger gender diverse children and youth population seeking services, and then parents take on a more active role in seeking appropriate care for their gender diverse children and youth. And from my clinic, about a quarter of them are prepubertal children that come seeking services and assessment from us, and that is a significant increase over the years. So some of the other possible reason is more available information through media and social media. And I think we just did a research and presented in Tokyo. We're talking about why some of the kids, they come out, and a lot of time they don't necessarily come out to their parents first. Where do they come out first? In social media. Because that's a safe place for them to be able to test it out, to explore their gender identity. So a lot of times social media has been served as a very a safe place for them to explore and consolidate their gender identity. And there are more open discussion about these populations through media, through news, and then they learn that there's a way to change. When I do the assessment, a lot of times that, especially for some of the population, they say like, I thought I just had to live this way forever, for the rest of my life, until I met someone who is transgender, until I learned that there's a way that I can change to be who I am. And therefore, I'm willing to come out now. And then they change the social norm and acceptance. I think our society more open up to other sexual minorities, and able to identify early on what their feelings meant, which is very true. When I do the assessment, a lot of times that they will say that the young kids, they say, I just know that I felt different than other boys and girls, but I don't know what that is. Until all of a sudden, I learned that there's a term called transgender, and I was able to research it. I looked it up, and surprise, I able to identify the feelings that they're talking about. All of a sudden, I have the vocabularies. It's so funny, when you have the feelings, when you don't have the vocabularies, your feelings is not validated. When there's a word for that, then you can describe to people how you feel, what that feels like, and what that meant. So for gender-variant children, as gender-diverse children and youth approach puberty, about 10 to 13, depends on the assigned male at birth, assigned female at birth, they tend to be more clearer with their gender identity because of the following reasons. They have exposure to different social environment, they're more mature, they're able to have more self-awareness, more knowledge, more exposures, and the physical changes, which is also bring a lot of anxiety. Because they feel like, a lot of times the young kids would tell me, I thought that if I pray hard enough, I would not reach puberty until all of a sudden my period comes, until all of a sudden my voice starts to crack. Then they know I cannot deny this anymore. And then the emergence of their sexuality, exposure to more sexual diverse persons, I think that's very helpful too. And then that's why we need to continue to have Soji, to continue to have people able to role model, to speak out about this so that there are people like me out there. In recent years, children request earlier medical transitions, and then probably because parents are unsure when to act or should they act at all. So they have a lot of questions. When is a good time to see Dr. Wong, Dr. Kisok, or some of you guys? When is a good time for us for hormone blockers? When is a good time for hormone? We don't know. Or should we not do anything at all? Or wait till, because that may be a phrase, what should we do about this? So they have a lot of questions about this. When is a good time to help my kids? Professionals do not feel well informed and trained to help make these decisions. So I think that's good that we have a discussion like this today. Hopefully we're able to open up a door, open up more questions, able to help you guys in the future when some transgender kids or youth knock on your door, so you'll be able to make some informed decisions to help support the kids. And professionals may feel uncomfortable, lacking resources for different reasons, or fail to provide support for the child and the family. And sometimes they feel like, I'm not comfortable, I'm not trained, so that as a result, they're not able to provide the service that they would like to do. And parents and clinicians also have several concerns too. So they would say, like, a lot of parents may say, am I doing the right thing? The parents always ask you that questions. Am I doing the right thing supporting my 4-year-old kid? Should I let my son dress up, put on a dress to go to school? Should I let my daughter to use the boys' bathroom? So all those questions will come to you, and you will, a lot of time, you put on the spot to make that decision and provide the answers. How will others judge me? And that is very common, the parent will ask. And especially from my cultural heritage, being a Chinese, the collectivism. It's like, because am I doing this is one thing, but how am I going to explain to my in-law? How am I going to explain to my Chinese neighbors that I let my son put on a dress to go to grade 1 when everybody knows that my son was born as a son, right? And how will other people judge me? I think it's very easy for some people, if they don't have that challenges. But for my family, we live in Richmond. In Richmond, we call it Vancouver. It's basically like almost like 80% of the population are Chinese or more. So my parent can go about the whole day without speaking a word of Chinese. I mean, without speaking a word of English. So he can go to the butcher, go to the cleaning lady, everybody speaks the same language. So imagine how that they can explain to their neighbors about it. And think about it this way, if they support me as a transgender person, and knowingly the family and the area will not be as easy on them to support me. What are the choices my parents may have? They may have to uproot and move to, a white area. And my parents, if they don't speak Chinese, don't speak English, how are they going to support me? Think about the globally now, comprehensively now. So put on a lot of weight on you when you give recommendation and ideas and suggestions for your clinic. I want you to start thinking globally, comprehensively, systematically when you give recommendation for your your Indian client, your Muslim client, your Mormon clients. They all have their community they live in that they rooted in. And if they want to choose to support their transgender kid, what are the sacrifices? Not just the kid has to make, the parents has to make. What about the grief and loss that they have to face? So that makes you think twice before you give the recommendation, tell the parents what to do. Let me give you one example. One of the doctor, and then a very nice doctor, and then they tell one of the Chinese parent who is maybe in their 20s, and they tell the assigned male at birth transition into a female. And then he said to her, so like, if you really want to be who you are, to have this hormone treatment, you really need to move out from your family to be who you are. Otherwise, it doesn't seem like you're sincere or ready to move on. So sounds makes sense, right? Individualistic, gung-ho to be who you are. But think about put yourself in my shoes. If someone tell me I have to move out from my parents to be who I am, which is really quite against the collectivism, because he is encouraging me to be individualized myself. Does that make sense? So you can imagine how that illogical for the parents and the clients, but at the same time, you can tell the clinician is really from a kind intention giving those recommendations. So just to be disclosure, like even though I am 60 years old, and I still live with my parents, and it's very, very common. And if you come to my house, it's 4 generations living together. So it's very, very common for ethnic minority in Vancouver doing this, given how expensive the house is. We all have to cram together, right, to afford the property tax. But beside that point, it's very, very common doing that. So like my house of 10 people living there and 4 generations living, and for us, it's normal. And so when you meet a client, be careful, especially with this taboo area, sensitive area, be sensitive with the recommendation that you're giving. Have the holistic, comprehensive thing in mind, the cultural perspective put in mind, the collectivism put in mind, because your recommendation can be really kind, good intention, but can come across very rude and insensitive. So next one, how do I going to explain to my extended families? Of course, I talked about that earlier. And should I do nothing and wait? Many, many parents will tell you that that's the decision they want to do. And so how about that? I just do nothing. When my kid's 18, he can decide whatever he wants to do. But right now, the kid live with me and have to do what I say. So which is good, and my decision to decide not to do anything. At that point, as a clinician, what should I say? And this is what I think, I recommend you should say, but you can ignore it. I think that we should let them know inaction is still an action. Indecision is still a decision. We need to let them know if you choose not to act, fair enough, you are the parents. But as a clinician, I need to let you know the pros and cons of these decisions. That is our job. Our job is to let you know any decision you make, we respect that, because your kid's a minor, you're the adult, and we respect it. But it's my job to help you, to give you the information that you need so that you can make informed decisions. Let me give you an example here. A lot of times when the kid, they are maybe like 13, 14, 15 years old, anybody have teenagers as kids around this age? Raise your hand. Good, quite a number of you. So what did they do if, let's say, it's an assigned female at birth as a girl? They may say, oh, I have a crush of this guy, I date that guy. 2 days later, I dump him, I go to you. And then 3 days later, I dump you. I try to date a girl instead. So, but this is very normal, right? That's what teenagers do. We date, we learn how to establish relationship, we learn how to dumb down, we learn how to deal with breakup, we learn to pack ourselves up and move on to the next guy. And that is a very healthy developmental task to do. But for the transgender kids, they may put that on hold. Think about that. So all of a sudden, everybody moving on through the trial and errors, able to get the skill that they need, navigate those developmental tasks. And all of a sudden, the transgender kid, what happened to them? They're being held behind because they don't feel comfortable. How will people feel about me if I have a penis between my legs and I'm dressing up as a girl and want to date a guy? I can't do that. I better not date. I wait till I have complete surgery done, makeover. I pass well, then I will date. By then, what are we talking about? 25, 22? If it's lucky with our wait list right now, right? So what are we talking to be? At that time, that person is 25 years old with a dating skill who is dating back, what, 14, 13? Think about this. It's really detrimental if it's someone who looks 25 with a dating skill of someone who's 14. All of a sudden, they make mistake. They become very immature. They don't know how to deal with all those things. And then we hold them accountable. Look, see, I know transgender people have mental health issues. Look at them. They can't even deal with handling their breakup and all those things. But we didn't think how our society or how along the missed opportunity really groom them and make them miss out those opportunity to meet their developmental needs. Does it make sense? So think in mind, working with children and youth, I love it. But always, always keep the developmental stages in your mind, because that is how you develop your treatment goal. And that is how you make recommendation, because you think not just what to do at this moment, you think about how I help this kid meet all their developmental needs, how I think about the culturally, the family system to best support this kid. So, and then, of course, the big what if, right? They're always saying like, what if this is a phrase? What if they grow out of it? And we will talk about this statistically later. And however, some parents may also plan to go too far in advance and request intervention that are ahead of their kids' developmental needs. So I see some parents, they're on the other end of the spectrum. They're gung-ho about it. They jump on the trans wagon. I am the supportive parents. It's just, my kid will, 13 will do this, 15 will do this, 16 will do this. I have everything done already. Everything will go ahead of them. And this is also can be detrimental too, because we know gender is a spectrum. That we need to allow the kids time and opportunity to explore and consolidate their gender identity. We don't need to get ahead of them. We allow them to lead, and we follow, and we provide the support that they need. And that's all we need to do. So diagnostic considerations. So to make the DSM diagnosis for gender dysphoria, as you can see, so I'm going to go over this real fast here. So number one, have a strong desire to be the other gender, the strong preference to cross-dressing, similar. This one is for children, okay? Adults, different one. And then a strong preference for cross-gender roles, so the make-believe play, they will be, I be the girl and you be the boy. And then a strong preference to toys and games and activities, and that will be not aligned to gender, so maybe I'm into Barbie girl, and then not train and trucks. And strong preference for the playmates or other genders, so I prefer to play with girls instead of boys. And for boys, a strong rejection of typical masculine toys, games, activities. And then number 7, a strong dislike of one's sexual anatomy. And then number 8 is strong desire for the primary and secondary sex characteristics. And you need to have 6 of them to be able to make the diagnosis for gender dysphoria in children. So let's look at the case here together. So White is 7 years old, Chinese boy, new immigrant from Hong Kong. His parents concerned about his feminine presentation. White admitted that he liked to put on his sister's dresses and hoped that he can wear them more often. He liked watching stereotypically TV shows that are for young girls, like Hannah Montana, that kind of shows. At times, he will pretend to be those female characters on those shows. And he was also put on a hand towel. And what he does, he would tie a knot of one end hand towel and put it over his head as if he has long hair and pretend that he's a female. And he does not like to play with boys and admit that he wants to be a girl on several occasions. So if we go back here, so White basically have like more than 6 of them criteria here. So therefore, for White, he meet the diagnosis of gender dysphoria in children. But interesting to share with you that I know White is not transgender. In fact, I can 100% guarantee you white is not transgender.
Yes.
Why? Because I am white. And that is me when I was a kid. Imagine if my parent got ahead of me and sent me to some doctors, nothing, and who will be like say, hey, you know, and this kid, he will just all he needs is transgender. Then I will be misdiagnosed that way. I just happen to be gay, very gay, but I'm not transgender. So is there something wrong with me? Something wrong with the doctor? Or something wrong with this? So I want to hear the raise of hand here. So this is especially target the female. So let's have everybody stand up. Only the female, sorry about that. Or identify as female. Any way you want to. It's a fun way. Okay, right now, who those put on a dress, you can sit down. Who those have a dress? Okay. For those who have makeup on, you can sit down. Ooh, I see more and more transgender people. No wonder my office is so full. As you can see, many of you already have signed that meet the transgender diagnosis criteria here. If your parents are very, very ultra feminine, they can see, oh my God, something wrong with you. Something wrong with you. Something wrong, you. All have you. Okay, thank you you can sit down now. So you can imagine, how can we not make the mistakes? Because we were told, we were trained to look for those things as signs of pathology. All of a sudden, if you come to my office, identify as female, and you still dress up like a guy, I don't know, are you really trans? Are you really trans female? I used to look like you are more muscular than my neighbor lesbian Susie that I know. Right? So I can make you all of a sudden you doesn't fit in. And then the other one, so if you come to my office, you identify as male, but you still like long hair, have lipstick on, and have, oh, God forbid, you have a double D cup and you like to show it. I just think, no, I think something wrong with you because you don't fit the picture here. So think about how we easily create biases that will help make us make the wrong diagnosis, make wrong assumption. At the same time, we create a wrong treatment plan that not quite fit our clients or their families. So this is what have the problem with the DSM. So how did this diagnose the different gender non-conforming children versus children with indeed gender dysphoria? No, you cannot. And the DSM would assume clear-cut differences in proper male and female gender behavior, and therefore atypical female or male sex role in young children all of a sudden are considered signs of pathology. And how did this diagnosis different gender non-conforming, gender variant children and children with gender dysphoria, repeating? So we all of a sudden we're pathologizing atypical gender role and diversity. And then also we are reinforcing sex stereotypes. We understand that not all pubertal children with gender concern will seek sexual reassignment after puberty. And this is very true, especially for many of my assigned female at birth. They identify as a male. Many of them, they don't necessarily need to have the bottom surgery. And it's very interesting to see a lot of times that when they go on hormone treatment, they pass well to be who they are, and everybody see them and treat them as male, and they feel that's good enough. If my partner don't care that I have a small penis, big penis, or no penis, so why do I subject myself for the surgery? right? So keep that in mind. So not everybody need to go through the whole 9 yards. And some parents, they may feel this way. So they will say, okay, at some point my kid needs to have blockers, and then hormone, and then top surgery, bottom surgery. They have the whole map out, but along with their with their tax plan and everything. But that's not true, because if gender really is spectrum, everybody is unique in your office. Everybody's treatment plan may be a little bit different from the other next patient that you're going to see. So gender dysphoria in childhood is more likely to continue with their transgender journey. So research telling us the more significant gender dysphoria, the younger they come out as, the more likely they continue with their transgender journey. So adolescents with gender dysphoria have usually had gender concerns since childhood. Not all children with gender dysphoria continue to have gender concern in adolescent adulthood. So you have to think of it both ways. And then indeed, gender is a spectrum. Therefore, we need to really look at it in a unique lens, and everybody is different. Don't just because they're transgender and give them the cookie cutter recommendation and treatment plan. And then, so another more problem with this DSM is a gender diverse individual can easily be interpreted as pathology. And it is assumed that boys and girls should wear different clothes, and strong desire to wear clothes of the opposite gender are signs of pathology. All of a sudden, what you play is also a gender activity, and cross-gender play has become a sign of dysfunction. And cross-gender behavior can be very anxiety-provoking for parents because of that. So when you're doing your assessment, the first thing is very important. What you're looking for is consistent, persistent, insistent. So when the kids come out to you, a lot of the time you want to go back how early they have those thoughts, those feelings that they feel different than other kids. A lot of times when I do the assessment, I always, doesn't matter how young, even they're 3 years old, I will use play and art to help them to tell me their story. You want them to tell you their story as early as how they feel differently about themselves. And also, the early childhood feeling is very important. They may feel different than other peers, and what does that feelings mean? They may not have the vocabularies to explain, but it's important for us to listen. And some may have typical early signs, like some of my 3-year-old, 4-year-old clients, they may have early signs. And some can potentially masking it, denying it, ignoring it as a way to cope, to fit, and to survive. And we all those that we see many teenager kids, they do that. And some of them, they may be obtaining information from multiple sources, from parents, from school, from therapists, and using different assessment tools, both qualitative data and quantitative data. I think both are important. A lot of the time people, they ask, okay, when I do see the transgender kids or youth, what kind of assessment tools we will use? I think that quantitative data help find out their mental health level, find out different the coping mechanism and things like that. But at the same time, qualitative data for me is give you the rich picture of what is going on. A number doesn't tell me much. A number just tell me where they are feelings, where they are compared to other kids of their age. But I want to know the juice. The juice is have them to tell you the qualitative data, their journey, their story, their struggles. So I don't know if you can see it. I cannot see it. Okay. So this is some of the questions that you can use. So I encourage you, you can take a picture of this if you want to. I just listed some of the questions that I post here. So I'm going to go here closer so I can read. My now getting all sucks. So what are the nature of the gender concerns? So you want to know about that one of it? Maybe I can read it here. And then so you want to know when did the feelings start? Are those feelings consistent? You want to know the impact on the adolescent's life, how they impact their friendship, their relationship with their family, how they impact the school life. And then you also want to know the feelings about transgenderism. So what do they feel about being transgender, any internalized transphobia going on, all those things. And then also relate our coexistence factors, so different things that other factors that you need to think about. So when we do assessment and differentiating, so I think a lot of times I list out what I normally know. If you know some more, you can add on and let me know. I'm more than love to add on more information to this. I like the biopsychosocial approach. So that is learning about the biological factors, psychological factor, and the social factors. And then I also like the development stage. Like I said, it's very important to also have that developmental frame in mind, especially working with children and youth. And then the family dynamic. Every family is different. How supportive the family is, how the family deal with sex and gender matters. Are the parents able to talking about this? Are the parents well informed in those areas? Are they come with the collectivism versus individualism? Are they immigrant? Are they acculturate to our society culture? So next one, language and culture, that is very, very important. So also like what language they speak, do they understand what transgender means? For some culture, they may not even have the word to describe how that is. Like maybe for the ethnic minority here, how many of you have your culture have a word, have a vocabulary for saying genderqueer? What about demi boy? What about, third gender? A lot of time for me, Chinese, we don't even have those words. So how are you going to help the parent to understand that phenomenon and help them to accept this is real when there's no word for it, right? Think about that, how powerful language is. So, and level of support and resources, and that is very important too. So, if you live in a rural area, the level of support and resources available quite limited and scarce. And also, if you're ethnic minority, immigrants, the support may not be available for your ethnic group. And even though when it is available, the ethnic minority parents may not feel that it's trustworthy. Right? So a lot of times that my parents, I remember, imagine if you tell my traditional parents, you know what, your son is gay. Why don't you go to a gay support group with a whole bunch of white folks sitting there and talk about your son being gay? They would never, ever, they would never break a leg than go to those groups. Let me tell you this. So you can imagine that. So a very important thing about this. And then, oh gosh, it's so bad, my eyes. And then differential diagnosis, disassociation, suicidal ideation, autism. So all those it need to be differentiated when we're doing the assessment with them. And then also need to consider the cultural consideration, the first generation versus second generation, or that too. So the family, the parent, first generation, the kids are second generations. You can see there is a lot of cultural conflict there. And then talking about the son is already quite westernized, so just let me be, I want to be individual, to be who I am. The parents still quite collectivism, so no, how can I let you to go down to astray this way? And then also the ethnic minority stress and the culturalization. And that's one very important to understand. Being transgender is already have a lot of minority stress. If you happen to be an ethnic minority, and then all of a sudden you become the double minority. If you come from another more conservative religious group, all of a sudden you are also another ethnic minority. So a lot of self-disclosure. It's not about me today, but oh well, it's about me now. So I happen to be a Mormon. Yeah, you don't know that, right? So if I have to leave the Mormon church, the only way for me to be gay is to leave the Mormon church. And I talked to Dr. Kissaw earlier. I went to Hawaii. I went to Mormon University. That's the only way I don't have to pay for my tuition. But that's not the truth, though. But the truth is, like, because my part of my family happened to be Mormon. So imagine if my family live in Utah, and imagine if I happen to be transgender, what do I have to do? My family have to live generation living in Utah and move out to, I don't know, let's move to Vancouver. And think about all the support, all the extended family, all those things that I have to give up. And just amazing loss and grief that they have to go through, right? I think it's interesting for us to think about all those things. And then internalized transphobia, definitely that's part of it too, for us to into assessment. So the next things that a lot of times that we need to think about is this circle. So I want you to keep that in mind when we do assessment. Of course, they come to you, maybe have a lot of gender dysphoria, but we also need to understand the minority stress. We also understand the mental health problem going on, so how they overlap. And a lot of times that because we help the kids to transition, and sometimes we use an informed consent model. And sometimes I think that some of the clinicians may make the mistake is, because you're so active suicide, we cannot let you to go on hormone. Because you're so active suicide, we cannot let you to have the surgery. And keep that in mind. If I'm really gender dysphoric and you don't give me my hormone that I need, you are making me more suicidal now, right? Imagine I have to live 18 years. Finally, I'm able to go through to have hormone treatment or surgery. And yes, I happen to have depression. I happen to still feel suicidal because it's so miserable living this way. And now you deny me just because I'm suicidal, because you don't think I'm emotionally stable. Then you're really making me suicidal. So keep that balance in mind. Make sure when you do the assessment, yes, mental health, mental stability is important. But at the same time, we need to know how they overlap, how this area here, they can become in you with a lot of this, but many of them can be deal with this. Does it make sense? So when you do the assessment, keep that in mind. So mental health support, what we know is 53% report needing counseling related to gender issues, and 30% require mental health assessment related to transitions. 39% report needing mental health care not related to gender concern, though. Maybe they have different issues, maybe autism, maybe OCD, maybe PTSD. So when we're doing assessment and continuation of care, so I think that we need to know that sometimes you are doing more than just an assessment. A lot of time, Dr. Kisop will know, after that we do the assessment. I always tell the parents, after 2 months you go on hormone, I want you to meet back with me. I just want to check about your social emotional adjustment while you're on this treatment. I'm not saying that you will have problems, but I want to see how you're adjusting with the medication. And also with the change of the gender role and with the change of all those system that you're in. What that means is, for example, some of the transgender clients will tell me, especially when I assigned male at birth, now I'm going hormone, I pass really well as female, and they didn't know our society actually have a hierarchy system for gender. Of course, if you are white, Caucasian male, you're on the prime cut. And then all of a sudden, if you're a female, you're on the lower cut. If you're a colored female, you're even a lower cut, right? So imagine if I transition, if I'm happen to be a white male, transition to be a white female, all of a sudden, back then, when I'm being boss, I can be assertive, telling you what I don't like, what I dislike. And guess what? You will listen. But all of a sudden, I'm female with a dress on, and I'm being assertive, demanding what I want to say. All of a sudden, you call me a bitch. You did. Why? Clients say, oh my God, that is so new to me. I never expect that was change. So that is the thing that you want to check with the client, because they are not just changing about their gender identity, they're changing their gender role. Their gender, how you assume who they are, assume the power, assume the equalness is changed, all according to that. It's also for us, hey, it's like to check with that. So as a result, that you also help them, you want them to check with their coming out, body image, mental health, family issues, and the list go on and on and on. So that means not a lot of time when you finish assessment, your job may not be done. The continuation of care may be just the beginning of the support for your clients. So, so these are the studies that I love to share. And there's a more recent study about how many of them, they changed their mind. So, So this one, the Olsen County study, this one is quite recent, 2022. About 94% of trans youth continue gender-affirming care into adulthood. So that's quite good. So only 6% of them, they changed their mind. But there's other story for this study, but let's just stick with 94% for now.
Is that North America? Or what?
That is North America. Yes, North America. And in Japan, 97.5% of the youth on puberty blocker continue on hormone. That is a very good statistic telling us. And then, and this one I cannot pronounce the name, it's a Dutch person, 90% of trans adults between 1972 to 2018 had no regret after medical transition. And lastly, and this is also from the Dutch, 96.9% persistent in trans adolescent after social transition. I think those are good to know, because a lot of the parents, they tell you, oh, what if what if they change their mind? So in fact, the regretful rate is really less than 1%, but there was a more recent study. So it's like, I'm talking about like 2 to 4, 6% people, they really alter the gender identity or the treatment. So many of you, so that I will also tell the parents, so they say, oh, that what if they regret? Because the statistic, what did they say? I would say, you know what? When you decide to marry your wife, do you know that there's a 50% chance that you will regret your marriage? And yet, you chose to do it. And yet, this is saying that your kid would have less than 6% to regret it, and yet you're holding him back, like something, right? So I think that is something, put them in perspective. You make those decisions based on what you value, all the pros and cons. You think this is the man or the woman, the non-binary person that you can spend the rest of your life with, based on what you know. And yet, the statistic telling us this, perhaps maybe let's put it in the right perspective. Let's talk about how we can support our kids. So I think it's also important, it's recent phenomenon, is gender I'm okay with time, right? Okay, all right. So gender dysphoria with autism. So more and more studies find a high prevalence of autism and autism related among transgender children and youth. And some clinic studies find up to 20% of clients have autism traits. And then a co-occurrence of autism and gender dysphoria present challenges in social adaptive, self-awareness, communication, and executive functioning complexity. Clinicians should pay attention to potential co-occurrence of autism and gender dysphoria and recommend assessment and support if it's needed. But I want you to keep that in mind. Just because the kids are autistic doesn't mean the kid doesn't know his, her, or their gender identity. They do. They do know that. What that make that difference is maybe how they learn to navigate the journey, how they come out, how to get support, how to follow step-by-step approach. That may be difficult. Or maybe the all or nothing. I want everything now. That may happen. So keep that in mind. So gender dysphoria and autism, so maybe harder to the youth with autism to comprehend the long-term risks and implication of gender-related intervention. So when you're making that recommendation, I always write them out, maybe list them out so that they can take home or so that they can able to go over them rather than just have them to telling them verbally. Develop a specialized consenting plan for the risk and benefit present in a concrete manner so that they're able to revisit, they're able to research, and they're able to take their time to go over them. And check for unrealistic expectations, so that is also important, especially if they're quite black and white with the thinking. So they think about, sometimes especially younger kids, they think if I just go on hormone, everything will be great. That may be true for some, that may not be true for some. It's our job to let them know all the pros and cons so that they're able to evaluate the risk and benefit. They may pose a higher risk for medical compliance and medical safety, so such as taking their medication on time and follow up with their medical checkup and refill the prescription because so many steps to do, so they may need more support. So it's good to have the parents in the room when you go over those pros and cons and then all those medical treatment that is involved. And just because the youth is on the autism spectrum does not mean the youth does not know his, her, or their gender identity. Although in some cases, gender symptoms appear to stem from autism symptoms, many youth have persistent gender dysphoria independent of their autism. An autism symptom can intensify an identification with gender dysphoria too, due to black and white thinking. So lastly, I think this one's the most important. We always ask about the family work and support because especially you working with children and youth. So a lot of time that not only working with your client, you also have to help to resolve and address family conflicts. You may have to provide resources and information. The youth with one close adult relationship are 4 times more likely to report good and excellent mental health than those who don't. So this is always a protective factor. And then meet with the parents, social worker, foster parents, sibling, extended family. So all those people can play a protective factor for your clients. And then, of course, there's an Infant Act in British Columbia. I'm glad that we have this law to protect us, but at the same time, this is always my last resort, only if I really, really have to use it. Advocate for transitioning while considering the risks such as homelessness. So a lot of times that, the kids can go on hormone, but they know that the kid will get kicked out by the parents. So it's something that you have to think about. So understanding parental concern and the opposition is very important. A lot of the time, I would say 99.9% of the time, the parents, they say no or they disagree with the son being transgender. It's not that they don't love their kid. On the contrary, because they really, really love their kids and they just have significant concern about what's going on. And the implication of the hormone treatment and then hormone therapy can raise various questions from parents about health and well-being. So we need to highlight those clear information so that they can make informed decisions. And then effective addressing parent concern effectively require empathy, knowledge, and open dialogue to foster understanding. So when parents have different opinions, so that happens quite a bit, especially when the parents, they are divorced, and then so one parent agree, the other parent disagree, or they never have a peaceful divorce, and now all the barrier differences surface because of the kid need to be transitioned. So for us, what to do sometimes really difficult. So what we need, I always tell the clinician here, documentation. Document all the parents' responses, who agree, what disagree, what you share, how the reaction is, because that is your protecting whatever that may happen down the road. allow equal input from both parents as much as possible, especially even though one parent happens to be less involved with the kid. When I do the assessment, I try to have equal time. So if I have one session with you, even though the other parent not involved, I will still maybe do Zoom, have equal amount of time, because if we go to court, so you want to say, hey, I spend equal amount of time for both parents, right? It's very important. Suggest seeking a second opinion. Sometimes it's okay to disagree with me. You don't have to agree what Dr. Wong say, because I'm not Mr. Know-it-all. You can disagree. Tell them, please get a second opinion. What you want to do is you want the second opinion, third opinion, fourth opinion, all saying the same thing as you do. Then you are in a very good place. Because all of a sudden, hopefully at that time, the parent will say, okay, maybe I should listen to the first doctor, because every parent is echoing the same things here now. And then also use wrap-around approach and allow input from other professionals. Sometimes they will think, hey, you are just a Chinese doctor. Of course, you're also always speaking for my Chinese son. You don't understand the Chinese parent, what they think. It's okay using wrap-around approach. So a lot of time I would like to maybe have Dr. Kisok to share about her opinion, and also have the pediatrician share about the opinion, have the family therapist, and then we all work together, wrap around supporting the kids. So if everybody cohesively saying similar story, it's a lot easier for the parents to buy into your recommendation and your assessment report. And I also suggest mediation. Sometimes the difference is so distant and they cannot come to agreement. I suggest let's have a mediation, have them to sort it out with a third party. If urgent, of course, if your client is just active suicidal, at that time something needs to be done, then at that time you may have to contact the protection services or emergency at that point. And so thank you so much for your time, and so hopefully we'll have more face-to-face talk about your future client in the future, and thank you.
PFLAG, it's listed on the TransCare website. It's a organization that supports parents, allies, loved ones, chosen family, people that are supporting LGBTQ individuals. So we went to a couple PFLAG meetings virtually, just to be around other individuals who, had maybe been through this journey before, or had, information to share with us. We just wanted to be around people that knew and understood. So that was the support for us. And then the other education support was the TransCare website. 5 years ago, it looked a lot different than it looks now. It's an awesome resource. I used it in particular for name change. So our daughter went through a legal name change, which is extremely confusing. And we used the TransCare website just to walk us through that. It's such a wealth of information. And then the other thing I thought, what did we need? I needed skills. So I needed skills to be able to communicate with my daughter. Like Dr. Wong said, I needed to know how to listen with empathy. I needed to know how to validate what was going on for her. I needed to understand. And I also needed support for myself, for my own emotions, right? Like I needed to understand, like, what did this mean for our family? I had a whole lot of anxiety about what this might mean for her. Like, was she safe on the bus? Like, was I, is she going to be bullied? What was going to happen when people in public looked at her? Like, I had all these concerns, a lot of sleepless nights worried about her. So I needed support for that kind of anxiety for myself. And also, there was just confusion, right? Like confusion. How do we handle the past? How do we talk about the past? How do we deal with the history? What do we do with pictures on our walls before she transitioned? So there's so many questions that families have. So for that piece, we had a family friend who was a doctor, and he recommended to us to contact Fraser Health Family Support Services. So I would recommend that as a resource. So if you have someone whose loved one is 19 or older, you can refer them to that. And what that offers is 8 sessions of clinical counseling free of charge, coaching. They have family peers there. I also got art therapy for free. You know, it was amazing. So I'd recommend that. And then the other resource that I found just through Google was called Emotions BC. And Emotions BC is a organization that supports caregivers, loved ones, chosen family, partners, siblings of individuals who might be struggling with mental health challenges. And like Dr. Wong said, in our case, there was some intersectionality between like the gender dysphoria and then the mental health challenges. So it was the place that I found that I could go to for the support and the skills piece. So what Emotions BC does is they offer online DBT skills training. So that was where I learned validation and empathy and what I can control and being able to see things from my daughter's perspective. And they also have, all their facilitators have lived experience and peer support, so I was able to kind of connect with a judgment-free, stigma-free group of people that we felt like we belonged with, that we could talk to, and that was where I learned, you know, radical acceptance of where we are today with our, you know, with our kid, and moving forward and figuring things out for our family. So I would recommend Emotions BC as a resource as well. And full disclosure, that was 5 years ago, and I'm now employed with them. And I'm now working as a family peer support and resource navigator with Emotions BC. And I'm going to be working at Foundry Surrey. So Foundry Surrey, wonderful resource as soon as it opens, probably July, I hope. We are going to be offering one-on-one peer support. Foundry will also have a family resource library there too, and other family peer support available. So those are some of the resources I would recommend.
If folks were here the first session, who was here the first session? Everyone? Yes, okay, great. You know, I was kind of asked to share about, you know, what were positive patient experiences, what were experiences where trans patients might have experienced obstacles. And then I also shared like a third experience, which was a cis patient seeking out like analogous care to a trans patient, like perimenopausal hormone therapy, and kind of making comparisons between the two. And I think how Dr. Wong really pointed out the stigma that's inherent in this care, what the social expectations are, and how that impacts, you know, even what's required for trans folks to often feel like they have to prove who they are when cis folks get to take that for granted. And, you know, I went through those scenarios with y'all, and I hope they were illuminating. But I also, you know, was asked to kind of focus in on you know, what makes a good experience at the doctor's office, and, you know, what can providers do. So kind of putting that responsibility again back towards the practitioner. And like a few things, and I was like, okay, well, maybe I'll do like a 3-pointer, but I'm just, you know, going to really say that, you know, regardless of all the minutiae, regardless of all the you know, ways in which pathways to care might feel complicated, learning about providing this care, you know, requires attention from you as a professional. Just getting back to like, what are the interpersonal and what are the relational skills that you really need to foster? And they may not be skills that everyone in this room has had to foster or been required to foster to succeed and be where they are now. Or maybe you'll disagree with me. I'm not putting critique out into the crowd, but I think one thing, you know, or 3 things here is open-mindedness for 1, empathy for 2, and the third one, and that I think is the most important, is letting your ego go, which I think for family doctors, for specialists, that can be really, really difficult. We do a lot of training. We go to higher education. We go through years, grueling residency, massive student debt. And then you come out on the other side and you are sort of in this like expert class, right? And I think that sets doctors up in a lot of ways to fail their patients. Because on the flip side, you look at trans patients, we're often highly motivated, we're often like insistent, persistent, right? But we're also often in an extremely vulnerable position coming in to seek care. We're in a position where we have like next to no power. It's the position in which we face maybe the most acute discrimination or some of the first really acute experiences of discrimination that we'll encounter in a journey of transitioning. And many of us know the stats, like, however number of trans folks are uncomfortable discussing gender-affirming healthcare with their provider, how many providers don't feel like they've had sufficient training. And we also know from our friends and our social circles, I think to expect like a bumpy experience at the doctor's office or at the ER, and that can be really discouraging. And again, that's also, it's really intersectional, right? That depends on a lot of factors, our social position, our age, our housing, living with parents, living in those intergenerational family structures, access to jobs, access to mobility, access to cultural inclusion, and what things, we are putting at stake to come forward to our doctors and ask for care. I think specific to here, right, like I think when we look at how care might be concentrated or regionally disparate, right, we're in a cost of living crisis. Trans folks live overwhelmingly above average in poverty. Moving to like Vancouver, where I live, where, we might imagine things are more possible, care is more accessible, community we might be more surrounded by. Those might not be like ready and immediate options to our patients, right? So I think what I really want to drive home is like really have some reflexivity. Think like you are in a position to decide whether that, patient comes away from this experience waiting, as Dr. Kissick was saying, 5-6 months to receive a referral and to get hormone initiation, and then, are you just going to take those harm reductive steps, or can you actually imagine going a little further, seeking out some of the TransCare BC resources, like the ECHO project or like the clinical mentorship call, and saying, really, and then going back to yourself and destigmatizing that, so I really just, I think my reflection from the first session, I think now is like a recognition of the power that you have over your patients and over their experiences, whether they're dealing with mental health challenges that might be exacerbated because they can't get the care that they need immediately, and really how can you come in and do that life-saving role that you trained all those years to be able to do. I think just kind of overarching, wanting to reflect on that, reflect on the power that you hold, and also the wonderful privilege that you have to make such a meaningful difference in these folks' lives. So, yeah.
Look at that document.
Yeah. I wish the MSP paid for it, but it doesn't. So unfortunately, so I think that if you have sometimes some child mental health clinicians, they are competent to do the assessment. They may, and if they do that, then your child and youth assessment is likely to be free and be covered. But however, if you come to seek otherwise, then you may have to see someone like myself who have to see us privately. So unfortunately, MSP doesn't really quite cover that. If you have extended health insurance, then that a lot of time it does cover seeing a psychologist, so that may cover some of the fee. So that is good. In terms of how long the assessment take, normally for children and youth, I really count on 3 sources of the data. The first data that I would like to have is from my client. Like I said, I really want to learn about their story, their journey, so that I can understand what they're struggling with. And then second set of data, I normally give them some of the standardized tests. So I just want to know the level of mental health, where they are in the depression, anxiety, and things like that, and some gender questions that we may have. And then the third set of data is the family input. I always have a session with the parents alone, because I think it's very, very important to hear the parent perspective, not just out of respect, but also they know the kids way better than I do. I want to see they support or not to support, at least when I write the assessment report, I know I will be able to address the concern that the parents may have. So that because the kid really counting at your mercy to be able to get the green light to get what they need. So, but the parents maybe is a gatekeeper to allow this treatment to happen or not. So have that session with your parents so that you will know what their concern is, and you can write the report as a way to answer the concern, so that they is more likely to get the green light to get the child, to give the child to get the support that they may need, maybe blocker, maybe hormone, or maybe just purely social transition, nothing else.
So in that document, the one that we've talked about so much, you'll have that separated out into the MSP covered services, again, very much geared towards our youth, but they also, we're good? Okay. I thought that was my mic, sorry. So there are some services which are covered. Unfortunately, some of the free services are mostly limited to those folks living in BCH.
Does anyone else have a response or would like to respond to that question?
Can I just add something? You can also fill out that HRA, and we will accept it, and then it will be MSP covered.
Thank you. That was my next question. I'll ask this question in the interim. What is one thing, and this would be a question for all of you, what is one thing you would want to tell providers as a bit of like, knowing that we're sort of closing our time here, is there one thing you'd like to pass along to providers who are maybe interested in providing gender-affirming care or already are, as a bit of a takeaway or a learning or an opportunity when they leave here today?
I guess we talked about how gender is a spectrum, so providing gender-affirming care can be a spectrum. So my foray into providing gender-affirming care was starting maintenance on patients. So my work at the UPCC, we got referrals for a lot of patients who wanted gender-affirming care. A lot of them already, unfortunately, had family doctors who were uncomfortable providing that gender-affirming care, so they were transitioned to our clinic because I was apparently capable in that, but which was something I wasn't. So don't be afraid to learn, and that's part of the journey. As a family physician, so much of our work is sometimes cajoling patients to be adherent to therapy. Like I was reflecting on just the care I provide, and that hypertensive, I have to beg, try to get them to take their medication to monitor their blood pressure, and like every visit is that cajoling that they're not there yet. But my gender-affirming care patients, they're the most adherent patients I have. I'm like, I feel like I'm not doing any work in there. I'm like, what are you guys doing on the weekend? Because I didn't do anything for you other than just, here's your medication, you're already doing everything that you need to do. So I don't know, that's the spectrum of human beings, and it's a neat thing to it feels like you're not working when you're providing gender-affirming care sometimes.
I would also like to add that gender-affirming care doesn't mean that we are just refilling their prescriptions. It also means acknowledging the patient, having that relationship of trust, and recognizing that most of their concerns may not be concerned to their sexual health, and just kind of having an open mind to what the patient has to say.
Would anyone else like to respond to that one?
I will echo, this is by far the most rewarding part of my practice. When that A1C goes from 8.4 to 8.3 to 8.4 to 8.6 to 8.7 every 3 months, but we have to see each other in the office. And then I have my patients where I just celebrated 6 years. Our 6-year anniversary of the first patient I started de novo on hormone therapy. And we always laugh because right now it's a social visit. And I know her grandma from Ecuador, and I know her partner, and I know whatever she's studying and what her grades are that semester and what she's struggling with. It is a very motivated group of patients that very often are very educated about the care that they're looking for, to the point where I very often tell them I only have to see you twice a year, not because I don't want to see you, but because let's not over-medicalize this, right? My favorite line I say to my kids is kindness and love, the things we need most, which is a quote from the Grinch movie. And I find that I really feel that in this section of my practice.
Cool. So the next question, and this might be one of the last questions. I know folks are sticking behind this. Is very awesome. Thank you for staying. Should we change the sex marker for trans clients on health records to their newly identified sex so they don't get misgendered? Gender doesn't show up as clearly. So this is a health records question, and would invite people to answer this and with whatever advice they might have around this complex topic.
Okay, so I deal with this a lot because I see patients on the entire spectrum from being transitioned to me from the BC Children's Gender Clinic where they've been on hormones for 6 years and we just kind of laugh our way through the consent table to starting somebody on hormone therapy from the beginning, and we have our very excited party when they come in to tell me, look at my new ID and look, my gender markers changed officially. Unfortunately, there are some barriers if you're changing it in medical records. So for billing purposes, it has to be the gender marker that is on their care card. I have also recently learned, and we've talked about this at one of our working care group meetings, UTI treatment can be prescribed to women by a pharmacist. So if you come in with UTI symptoms, you tell your pharmacist, they can give you the antibiotics. I have a trans guy who had changed his gender marker and was denied that ability, and the poor pharmacy student was trying their best to figure out how they could give them those antibiotics that they needed for the UTI, but because the gender marker officially on the care card had been changed, they were not able to provide that service.
Sure, maybe I can just add that, it's obviously so complicated and there's so many kind of unexpected ramifications, I guess, or I wouldn't want to call them consequences, but basically system failures that happen because our systems aren't designed with trans people existing in mind. But there is a lot of work being done around gender and sexuality health records keeping, and that work is ongoing. But I think the movement to really think about people in terms of their anatomy, in terms of what organs they have, in terms of whether this person has a uterus and what does that mean about their health care. There's so many things that become drastically oversimplified with the M or the F. So I think that's also a thing to keep in mind. And if you're interested in advocacy, that's an area of advocacy as well, to remove those restrictions under MSP. Yeah.